Hello everyone, in this session, we are going to continue to explain the pathogenesis of inguinal hernia. Inguinal hernia is divided into congenital type and acquired type. In the early development of embryo, the testis is beside the second and the third number vertebrae, then descends gradually, makes the pretulium, the transversalis, facial and varices layers of muscle gradually move down through the inguinal canal in the meantime, and promotes the skin to form the scrotum. The peritoneum descending alongside develops into a processus vaginalis, and the testis closely clings to the parietal posterior of the processus vaginalis. Not long after a baby is born, her scrotum becomes the tunica vaginalis, propria testis, and other parts of the processus vaginalis shrink and are imperforated by themselves, leaving a fiber chorda. Without a trachea, the chorda can become a congenital indirect hernia, and the processus vaginalis not imperforated will become the hernia sac of the congenital indirect hernia. The descent of the right testicle is slightly later than the left, as well as the atresia of the vaginal process. Therefore, the inguinal hernia of the right testicle is more common. People acquired an indirect hernia more than those with congenital hernia, and its pathogenesis is completely different. Such a hernia comes into being because of an anatomic deficiency existing in the inguinal region. The inguinal canal region is a region within abdominal wall, where the strength of the abdominal wall is reduced due to passing by the spermatic cord. But a genetical indirect hernia is mainly induced by dysautogenesis of weak abdominal muscle, leading to the attenuation of the sphincter of the transversus abdominis muscle and the obliquus internus abdominis to the inner ring, and by a failure of the arcuate anal brim of the transversus abdominis muscle or conjoint tendon to approach the inguinal ligament during shrinkage. Clinical manifestation and diagnosis. The clinical symptoms of an indirect inguinal hernia vary from different stages of the hernia sac or the presence of any complications. The basic symptoms is a reducible lump present in the inguinal region, which is small at the beginning, only occur when the patient stands up, carries out a physical walk or coughs intensely, or when an infant cries and reduces and disappears when on a spinal position or pressing with hand. There is generally no spatial discomfort, and only a local distending pain and a referred pain should occasion. With the development of the disease, the lump increases gradually and descends from the groin to the inside of the scrotum or the neighboring majors pudendally, and the patient has difficulties in walking and in physical work. The lump is in a pear shape with peduncle, narrow at the top end and wide at the lower end. During examination, the lump can disappear when the patient lies on the back or is reduced in the interocilia, when it is gently pushed outward and upward with a hand. When grunt can be heard, for the content of viscera is the small intestine. After reduction of hernia lump, the examiner may gently pat the case fingertip into the enlarged outer ring along the scrotum skin and the spermatic cord and ask the patient to cough, and then a rush can be felt by the fingertip. Some concealed indirect inguinal hernias can be determined through this test. The examiner may tight press against the inner ring of the inguinal canal with fingers and then ask the patient to cough intensely. The lump does show at the moment, and when the fingers are removed, the inward and downward protrusion of the lump from the center of the groin can be observed. The inner ring pressing test can be used to identify indirect and direct hernias. For direct hernias, after reduction of the lump will still show when the inner ring is pressed by fingers and the patient coughs. The above are the clinical manifestations of reducible hernias. If the intestinal loop is contained visceral, the lump would be soft, smooth on the surface and give out tympanic resonance if being located. There is generally a resistance during reduction. Once the reduction starts, the lump disappears rapidly and grunt can be heard when the intestinal loop enters the interocilia. If the omentum majus is the contained visceral, the lump would be tough and non-elastic, give out dull resonance when being located and reduce slowly. The main clinical manifestations of irreducible indirectly hernia are the slightly severe swelling pain and the incomplete reduction of the hernia sac. As for sliding indirect hernias, the symptoms, in addition to the incomplete reduction of the loop, also include dyspepsia, constipation. Sliding hernias are common on the right side, and the left-right incidence rate is about 1/6. Incarcerated hernias normally occurs when the intra-abdominal pressure increases abruptly during laborious work or bowel movement, and are generally indirect ones. The common clinical manifestation is the abrupt enlargement of hernia lump, accompanied by an evident pain. The lump is reducible when the patient lies on the back or it is pushed by a hand. The lump is strained and hard and subject to hypophagia. The omentum majus is the contained viscera of incarcerated hernia subject to the slight local pain. In the case of the intestinal loop, the local pain would be invading, accompanied by the symptoms of mechanic intestinal obstruction, like paroxysmal abdominal colic, nausea, emesis, constipation, abdominal distension. The clinical symptoms of strangulated hernia are more severe. After necrosis and perforation, the intestinal loop may cause the acute inflammation or the septicopemia in more severe cases. A direct inguinal hernia is one that protrudes along the inguinal triangle at the inner side of inferior epigastric artery. Its occurrence rate is lower than that of indirect hernia, accounting for approximately 5% of inguinal hernias, and it is more common in elderly men and generally on both sides. Most direct inguinal hernias occurred, and there is no such congenital inguinal hernia. The main etiologic factors include dysplasia of the abdominal wall and weak muscles and fascia in the inguinal triangle. Because of the amyotrophy of old people, The gap in the inguinal canal is widened, and the supportive and protective function of the umbilical internus abdominis, the transversus abdominis, and the conjoint tunnel is weakened. When the intra-abdominal pressure increases abruptly due to chronic cough, habitual constipation, or dysuria, the transversalis face would be subject to impacts from the intra-abdominal pressure repeatedly, leading to damage, thinning, and gradual forward movement, and then protrusion of the viscera in the interocilia, and direct hernia comes into being. It is mainly a reducible lump in the inguinal region. It is in a spherical shape above and outside the public tubercle, without pain or other discomfort. The lump occurs immediately when the patient stands and disappears when he lies on the back. The lump would not get into the scrotum and rarely incarcerates because the neck of the direct hernia is wide. After its reduction, the abdominal defect can be touched directly in the inguinal triangle, and a swelling impact can be felt at the fingertip when the patient coughs. Tightly press the inner ring outside the abdominal wall with fingers. Ask the patient to stand up and cough, and if the lump still occurs, it could be identified as indirect hernia. Differential diagnosis. Though the inguinal hernia can be easily diagnosed, it can also be easily confused with the following diseases, and cares should be taken in identification. Identification of direct and indirect inguinal hernias. Indirect inguinal hernias, it is common in children and young adults. The content protrudes along the inguinal femoral canal and can get into the scrotum. It is an oval or pear shape. The lump does not protrude with pressing the deep ring after reduction of the lump, and as the hernia sac is in front of the spermatic cord while the neck of the sac is at the outer side of the inferior epigastric artery, its chance of incarceration is high. Hydrocele of testes. After attack, the lump can never reduce and is positive in the transillumination test. The lump is cystic and elastic. The testicle is in hairdrops and therefore is unable to be touched, and in the case of an indirect inguinal hernia, the substance testicle can be touched after the lump. Hydrocele of spermatic cord. The lump is above the testicle in the internal region, irreducible and small in size, has a clear brain and cystic sense, and would move up and down with the testicle when the testicle is pulled. Rush is not felt during coughing, and it is positive in the transillumination test. Communication hydrocele. The lump occurs slowly and enlarges gradually when the patient gets up every day or stands. Shrinks gradually when he lies on the back and after goes to sleep. Its volume can also be reduced by pinching the lump, and it is positive in the transillumination test. Treatment. Exempt for infants, self-healing of indirect inguinal hernias is impossible actions, and the treatment effect will be certainly affected as the lump enlarges, and the life of patients would be endangered because of frequent incarceration and strangulation. Hence, An operation should be carried out at the earliest time possible, except for a few exceptional cases. Non-operative treatment. It is generally considered that infants under the age of 1 may not take the surgery for the time being. An accountant thread tools or bandages may be used to press the inner ring of the inguinal canal first to prevent the protrusion of the hernia. For people not suitable for the surgery, such as elderly and people of poor physical conditions or with a severe disease, the medical hernia belt may be used. The prolonged use of medical hernia belt can make the neck of the hernia sac become thick and tough under friction, increasing the incidence of incarceration and could promote the hernia sac to stick on the hernia content. This is the disadvantages of using a medical hernia belt. Many reduction of incarcerated hernia, in principle, an emergency operation should be arranged for incarcerated hernias to prevent the necrosis of the intestinal canal. However, in a few cases, the incarceration time is short, within 3 to 5 hours. The neck tenderness is not apparent. This is an abdominal tenderness or signs of peritoneal irritation, and it is estimated that strangulation has not developed. It is especially the case for children, as their tissues surrounding the hernia ring are elastic, and the reduction may be treated. Patients have a long disease history and a large hernia, have a major abdominal defect, or have a loose hernia ring. Reduction method. Inject the Dolentin for sedation, relieving the pain and relaxing the abdominal muscle. Ask the patient to take a position with the head higher than the feet. Support the scrotum with hands. Reduce the protruding lump upward and outward towards the inguinal canal through uniform and slow pressing, and gently massage the incarcerated hernia ring with the left hand to assist the reduction. During the manual reduction, brutal movements should be absolutely avoided to prevent the intestinal canal from being damaged. After the reduction, closely observe the patient for 24 hours for the phenomena of abdominal pain, strengthened abdominal muscle and blood standstill, and also pay attention to the relief of intestinal obstruction. A successful manual reduction is only a temporary measure and has some risks. Therefore, its application should be strictly controlled, and the patient should be advised to take an operation at the earliest time possible to prevent the reoccurrence. Surgical treatment. If the intra-abdominal pressure increases before the operation due to chronic cough, dysuria, constipation, abdominal dropsy, gestation, the condition should be treated first. Otherwise, the hernia is likely to reoccur after the surgical treatment. There are lots of operation methods for hernia, which can be divided into 3 categories, namely the conventional herniorrhaphy, the tension-free herniorrhaphy, and the laparoscopic inguinal herniorrhaphy. Conventional herniorrhaphy, high ligation of the hernial sac, and reinforcing or repair of the inguinal canal wall. There are generally 2 types of operations which respectively reinforce the antithetic and the parens posterior of the inguinal canal. The inguinal canal antithetic reinforcing technique includes the Ferguson technique. There are 3 techniques to reinforce the pars posterior: bassinet technique, Hosted technique, McVeigh technique. Tension-free herniorrhaphy. In a conventional herniorrhaphy, the suture tension is high, and there would be a post-operation pain, referred pain. The tension-free herniorrhaphy is to repair with methods of an artificial high-polymer material without tension and has the advantages of less post-operation pain, faster recovery, less recurrence. Laparoscopic inguinal herniorrhaphy. It has the advantages of a small tumor, less post-operation pain, fast recovery, no local referred pain. Principles for treatment of incarcerated and strangulated hernia. An emergency operation should be arranged for incarcerated hernia to prevent the necrosis of its content and remove the concomitant intestinal obstruction. And as for strangulated hernias, an operation is absolutely necessary because of the necrosis of the hernia content. The key in making a decision on operation is to determine the vital force of the hernia content, and then the treatment method should be determined as needed. To determine the vital force of an incarcerated intestinal canal, first expand or cut open the hernia ring, and after the compressing on the hernia ring is relieved, determine according to the corner, resilience, and peristalsis ability of the intestinal canal, and whether there is artery for penetrance in the corresponding mesentery. If the intestinal canal is in purplish black without growth and resilience and makes no peristalsis after irritation, and there is an artery for both in the corresponding mesentery, it is the necrosis. If the intestinal canal is judged to be free of necrosis, it can be sent back to the intracranial and treated as a common reducible hernia. However, if there are lots of incarcerated intestinal loops, special care should be taken for the possibility of retrograde incarceration. Therefore, it is not only necessary to examine the vital force of intestinal loops in the hernia sake, but also to examine the intermediate intestinal canal in the intracranial for necrosis. If the vital force of the intestinal canal is suspicious, after the examination, inject 0.25%, 16 to 18 procaine at the routing of its mesentery, then cover that segment of intestinal canal with warm gases with isotonic saline, or send the segment back into the intracranial and observe 10 to 20 minutes later. If the intestinal wall turns into red and the peristalsis and the artery pelomis in the mesentery are covered, it means the intestinal canal is still white and is reducible to the intracranial. In the case of necrosis of the intestinal canal, or the pathologic change is not improved after the above retreatment, or it is difficult to determine the vital force of the intestinal canal for the time being, the segment of intestinal canal should be excised and enteroanostomosis should be carried out, provided allowed by the general conditions of a patient. When such excision and enteroanostomosis are not allowed by the patient's conditions, put the intestinal canal subject to necrosis or with suspicious vital force at extraposition of the abdomen. Make a small incision near it and insert a rectal tube to relieve the obstruction 7 to 13 days later. Carry out the enterotomy and anastomosis when the general conditions are improved. Never take any chance to put an intestinal canal with suspicious vital force back into the enterocelia. For patients operated with the enterotomy and anastomosis, the hernia-free should not be carried out after the high ligature of the hernia sac, and the operation zone has been contaminated to prevent the failure of the hernia-free due to infection. If the strangulated content is the augmented measures, it may be incised